Okay, welcome everybody to today's webinar presented by the Institute for Health Technology and featuring Dr. Alan Snell, Chief Medical Informatics Officer with St Vincent Health, and Julia Smalley, Project Director Innovation Accelerator Team with Ascension Health Alliance. My name is Matthew Rayner, and I am the Senior Marketing Manager here with the Institute for Health Technology Transformation. The Institute would like to thank everyone for attending today's webinar. Here at the Institute, we strive to provide programs such as today's webinar that drive innovation, educate, and provide a critical understanding of how technology applications, solutions, and devices can improve the quality, safety, and efficiency of healthcare. We encourage you to visit our website at www.ihealthtran.com to learn more. As a reminder, today's webinar will be recorded and made available for download along with the PowerPoint slides on the Institute's website. Once again, that is www.ihealthtran.com by close of business today. We will be hosting a brief question and answer session at the conclusion of today's presentation. So please feel free to send in your questions during the webinar by using the question section on your GoToWebinar toolbar. At this time, I would like to turn things over to Dr. Snell. Alan?
Thank you, Matt. And good afternoon, everyone, or good morning if you're in the Western time zones. Julia and I are very honored to be part of this today and present our study and talk about what that means and where we're going with the information. I had the honor of presenting this at the Seattle conference for IHT2 back in August last year. At that time, we were really just getting started. So today, this is more follow-up and some preliminary results that we can share with you. And then talk about what our next steps are. So over the next 30 minutes, we'll give you the information about the research study, how we've expanded the research study, and then how we're going to incorporate the findings of this important study in our strategy for both St. Vincent Health and Ascension Health moving forward. If you want to go to the next slide then, Matt. So on slide 2, as we begin, this is our obligatory slide to show you who St. Vincent Health is. We are the largest healthcare system in India. We just added, in fact, 2 additional hospitals on July 1st. So about $5.5 billion in revenue will be probably our fiscal year ended June 30th. So we don't have the results of that fiscal year yet, but we'll be probably close to $6 billion in revenue and growing numbers of geography and numbers of patients and numbers of facilities, and as many across the country are starting to see this consolidation. We have 8 critical access hospitals. They're listed 11 through 18 on this slide, and those are the small 25-bed hospitals, many of you know, that serve critical areas, rural areas, predominantly in Indiana. And that's where we are reaching out to them and connecting them to the same EHR platform and all the other applications that we have. And they've been involved in this study as well. Please. And slide 3 shows Ascension Health, which is the nation's largest Catholic. It's the largest not-for-profit health system. In fact, it is the largest not-for-profit in the country right now. And it continues to expand as well. And Julia is actually employed by Ascension Health, but it's based here in Indianapolis. The home base for Ascension is in St. Louis. Now over 500 locations, as you can see on the map. And we just are adding the Daughters of Charity in California. So they'll be coming on this year as well. Next slide, please. Yeah, you can go on to the next one, too. Okay, so to kind of give us a foundation of our Beacon research study, let's talk for a minute and remind some of you where the funding here on slide 4. So in 2009, as you're aware of, the stimulus package, the $787 billion, and high-tech received approximately 34 of that, and the $2 billion went to the health information exchange activity, and I'm sure many of you are participating in that in one way or another with the regional extension centers and the state HIE cooperative agreement program. But a small portion, when you're talking billions, 256 million is rather small change, but the Beacon cooperative program, 256 million, funded 17 sites. Now go to the next slide, please. So we, Central Indiana was one of the 17 communities awarded this, and Indiana Health Information Exchange, which is the nation's largest HIE, was actually the recipient of 16 plus million for this 3-year program, which actually launched in 2010. The program's intent is listed there: quality, efficiency, population health, somewhat aligned with the triple aim that the CMS and other government agencies are really focusing on now, but certainly with that technology slant. So what they were really wanting to know in these 17 communities is how can we use technologies and the health information exchanges to really make improvement in our healthcare delivery and reduce the costs. Next slide, please. So on slide 6, you see a picture of our state and the area, and I was on the team that helped write the grant for the Beacon Award. We had to pick a service area. We did not, and was advised not to pick the entire state, so we picked the hospital referral region from the Dartmouth Atlas, 183, which is counties. So that's half of our state, approximately. At that time, it covered 58 acute care hospitals and about 6,000 physicians, I believe. And then we have 2 regional extension centers, one at Purdue University in Lafayette and Washington, which also is the home of Indiana University. And between those 2 regional extension centers, it covers the entire state, and there's a lot of overlap with their activity and what we're doing with the Beacon grant as well. Next slide, please. So on slide 7, just a few facts for those about congestive heart failure. And the reason why we targeted congestive heart failure, it is the most common diagnosis for readmission in our nation's hospitals. A lot of focus has been paid on the readmission rates, the 30-day rates. So even back in early 2010, when we were writing this grant proposal, we knew that CMS was going to change the reimbursement for readmissions and install some penalties. And of course, now we know for sure that's going to happen October 1 of this year. But we knew that was coming, and so we wanted to set up a research study that could address this and help hospitals particularly learn how to do a better job on keeping patients healthy once they were discharged, because there are so many times that patients just come back, and there are many reasons for that. If it is just medication, not understanding their medications, not complying with their medication list, not understanding them well enough, and then also not even having appointments made. So there are a lot of things that we could learn from this study. And of course, then at the bottom you see $28 billion in healthcare expenditure. So it's a big target for CMS and the other payers as well. Next slide, please. So with that, I'm going to turn it over to Julia Smalley, and just a couple other words about Julia and her role in this. She is a nurse, master's trained nurse, has worked for several healthcare systems here in Indiana as well as across the country. So very experienced nurse, both on the inpatient side and the ambulatory side as well. So when we were awarded that subcontract for the Beacon grant to do this particular research study, so we received just under the $1 million out of the $16 million. Then I asked Ascension Health, who had helped on the preparation for the grant, but have 50% of Julia's time devoted to this particular project. Now she has other projects for Ascension Health around the country too, But so between Julia and I and a couple of other people and St. Vincent, we designed the study. And I'm going to turn it over now so that she can tell you about the study and the impact that it's had so far. Julia?
Thank you, Dr. Snell. As we looked at the study and figured out how to design it, we had the time frame of really April of 2010 when they announced it, and we were given a 6-month ramp-up period to begin this project. And we have until the end of this fiscal year to actually monitor patients. And then the first quarter of 2013 will be devoted to our analysis and our write-up of the study, and hope to publish this in results. The patient population, as Dr. Snell said, we asked the patients of CHF and COPD. This is a formalized research study. We have people involved from Brigham Street, Purdue, as well as Indiana University research team. So it was designed to specifically target these two populations, meaning on discharge, our patients have to have these two diagnoses. So oftentimes we run into patients that are admitted with COPD, but then their actual discharge diagnosis is pneumonia, which excludes them from our study. And in order to reduce and minimize as much bias as possible, there are some exclusions of criteria that we had to follow in identifying patients that could participate. For example, those that are on home health agencies qualify for that. They're not able to participate because we'd have no idea of whether home health helped or the remote monitoring, etc. So we have 30 days to patients. And the whole objective is to reduce our readmissions rate through teaching patients self-management skills. So while we want to provide coaching and assistance and information, it's really all about helping that patient identify their own trigger points so that they follow care physician before they end up in a crisis situation where they end up going to the emergency room, because then we know that 9 times out of 10, then they're automatically admitted into the hospital. Our form of measurement that we selected is the patient activation measurement tool that was created out of the University of Oregon, and we purchased a license to use this particular survey. And it's all around the confidence level patients have and the understanding of their own diagnosis and how to care for their diagnosis. So at the conclusion of monitors, whether they're in the control group or they're the randomized, or excuse me, they're in the non-control group, the intervention group, we ask these patients the questions to be able to show, is there a difference? And our preliminary results have shown that there is a difference in the confidence level that the patients in the control group have is less than those in the intervention group that we've worked with for 30 days. You want to advance the next slide, please? Matt, you want to forward the slide, please?
It is, Julie. We see it.
Oh, you guys see it? I don't. Okay. So to get started, to put a program into place, we had to establish the baseline for the participating hospitals. We started out with 13 different hospitals. These are, some of them are St. Vincent associated, and some of them are non-St. Vincent hospitals. We were very diverse across of hospital size, geographic location, to get a fair representation within the study. So we looked at their readmission rates for each one of those hospitals in CHF and with COPD and showed where they fell. And all of them, I think but one, was over the 21% readmission rate. So everybody had a lot of room for improvement. We had to obtain a formal internal review board approval at Indiana University, representing Wishard Hospital, which is one of our larger hospitals in the urban setting that has been participating. And then for the St. Vincent hospitals, they all were able to operate under this particular IRB approval process. We had to figure out ways to integrate this with the hospital discharge planning. So really, we came up with a formalized process, but then that had to be each hospital that was participating, because everybody's workflow processes are a little different, and as you all know, different size hospitals, some people wear more hats than others. So as we designed we had to keep it flexible and fluid so that as we went into these other hospitals and they integrated it into their workflow process, it still made sense and they were able to identify those patients so that they could approach them. Because it's a formalized study, a consent form had to be signed by the patients before that they even found out whether they're going to be in the control group or the intervention group. So in most cases, it was the care manager that approached the patient, talked to them about the study, and to find out if they were willing to participate. We also had to identify a device vendor. This was a little challenging, but we decided that we wanted to see if video conferencing had an impact on the care. There were a lot of studies already published, but very, very few actually use video conferencing as a key tool to their patient education and relationship development. So when we selected this as a top priority, that immediately narrowed our field down in choices. Now this was really at the beginning of 2010 that we were looking. Today that looks a lot different. But then there were 8 vendors. We sent out requests for information from them. From there we narrowed it down to 4 vendors, invited them to come into the hospital and present to a comprehensive group of clinicians, non-clinicians. It was a very diversified group, even including some people that had no involvement in the study but were from other hospitals so that they could add input. We selected a vendor at the end of the day. Care Innovation was formerly GE Intel. That was the device that we selected for this particular process. We had to prepare the site hospitals. It required some training, of course, with our nurses that were functioning from the call center, as well as the clinicians that were involved at the different hospital sites. We also had to select a third-party vendor, company, if you will, to go in and make these installations. The device is not one that you can just give to the patient at discharge and they go home and plug it in and it's up and running. We identified a company called VRI, Values Relationship Incorporated, out of Ohio, and they have a local presence in Indianapolis. And so when we identify a patient that's going to be discharged, we provide that information directly to VRI, and they make a contact with the patient to set an installation time 24 hours of their discharge at a convenient time. They go into the home, they set the device up, they orient the patient to the device, and then at that time our nurse contact center makes connections. We wanted to select nurses that had a lot of critical care experience, not knowing what we were going to run into, and also knowing that a lot of these patients, particularly with cardiac problems, are coming from the intensive care unit. So we selected trained RNs with that experience. We also had to build out clinical protocols. So we worked with our own internal pulmonary and cardiac departments in identifying what are the key components that we need to be focused on. And these also had to be prioritized so that you have a patient over the course of a 30-day period of time, but you start out with those most critical aspects of questions post-discharge that are really direct their recovery, and then as they stabilize and feel more comfortable and better, then we start gradually getting into other content that affects their disease factors, such as diet, exercise, lifestyle living, etc. And then the communication materials were something that took quite a bit of time. We created a patient welcome video, so the first thing that they saw when they began the project was Dr. Snell's charming face, and he acquainted them to the study and reinforced how important their participation was and how they were going to be impacting the future of remote care, and tried to establish that presence so we could minimize the number of patients that would drop out during the study. We also created a physician letter that we sent to each of the patients' primary care physician, as well as either their pulmonologist. This particular study does not involve their physician, but we didn't want that physician to be blindsided about their patients participating without their knowledge. So we provided some baseline information. We also offered them the opportunity to provide them ongoing regular reports on their patients, and if they wanted further information, they knew how to reach us to ask additional questions. We also had to create quite a bit of content materials to notify the patients so that they were well informed, the nurses at the bedside, again, to minimize biases. So we really only wanted the nurse managers or the case managers who were talking to the patients to consent them talking about the study, so it wouldn't sway the opinion of our patients whether to participate. Matt, can you advance the slide? To operationalize this process, as we said, it was a control group and an intervention group, so they were randomized. The nurse calls in. She tells us she has a patient that's willing and has consented to the study. We plug them into a blinded, really just an Excel spreadsheet that was set up. And then once the patient's name and information was entered, then it unblinded the column that told us whether they were going to be in the control group or the intervention group. So even on our nursing side, the nurses did not know which group the patients were going to be assigned to. We had to qualify the patients, making sure they met the criteria, and we enrolled them in the study, meaning we put the vital information we needed about their history and health and contact information in order to get started. Once the device was deployed in the home that same day, once the installer left the home, then our nurse made the first video contact. And that was important to us for several reasons, actually. One, we wanted to establish that face-to-face contact, start a relationship with that patient. We have only 30 days to work with them, so we wanted them to feel comfortable as to who they were talking to. We have a full-time nurse who works 4 of the 5 days during the week, and we have another consistent nurse that works the other 5th day during the week, rotating out different nurses on the weekends. But they've really gotten to know these 2 particular nurses that are there the majority of time and have developed a relationship and many times a friendship with these nurses. And that has a huge impact on the patient's compliance and their willingness to follow directions. We have daily interactions with those patients. We upload their biometric data, and they also answer questions. We phone calls as needed based on the results of the health questions and the biometric data to ensure that the patient is doing well. And then we have the video conferencing that we set up with them. As I said, the typical is 6 times during a 30-day span, but we can do it more often if we need to, and we can even space it out to follow up directly after their physician appointments. We also do the post-survey. We will be continuing our patient enrollment through the end of this year. And one of the other factors is that we wanted to be able to compare best practices with the different hospitals that were participating. There's a variety of transition programs in hospitals, and some are more comprehensive than others. So even whether you use remote monitoring or you do not, the processes that some of these programs have already put into place for their patient transitions definitely play a vital role in the success of their patients having to be readmitted or not. So we wanted to share among all the hospitals at the conclusion of the study what are just some internal best practices in addition to using remote technology. Can you advance the slide, please? This is really what our process looks like as we have it flow charted out. As I mentioned earlier, the case study or the case manager will connect with that patient and consent them. If they agree, then she calls our nurse, finds out which study they'll be placed into. We deploy the technology and begin video conferencing with them and and begin that process. Now, if a patient is selected for the control group, they receive in the mail right after they get home a letter from us just reminding them that they are in the study and what an important role that they are currently playing. They will receive, this patient in the control group receives that hospital's normal standard of care. So as I said, some programs are more robust than others. So in some of our hospitals, that's really not more than their prescriptions and appointment for follow-up, and that's it. And others have processes in place where they'll make numerous phone calls to check in with the patient for a given period of time. Regardless, we don't have any contact with the control group until the end of the 30-day period. At that time, we call them, we conduct a PAM survey as we do with the internal group, and at that time is when we find out, did you have to go back to the emergency room or an unplanned physician? Were you readmitted? And that's how we're able to identify those who are admitted or not admitted that we've not had daily contact with. Advance the slide, please. This is the way the infrastructure of the technology more or less works. As you can see, we have our nurse contact center located at St. Vincent's Hospital, and the nurse is able to monitor each of the patients as they upload their biometrics and their health questions. We are alerted to those that are outside of the parameters set, so we're able to follow up with them immediately with a phone call to first validate that the information is correct, and then secondly, if the information is correct, to give them the advice that they need to follow up with, whether that's contact their physician, etc. The devices that we have selected, every patient has a weight scale, a blood pressure monitor, and those with COPD also have a pulse oximeter. Those are Bluetooth so that they don't have to be tethered to the device. The information is automatically uploaded through device and back to the nurse contact center. On the first video conferencing, the two most reasons that patients we have found are readmitted is lack of medication reconciliation, and they don't follow up with that physician visit. So on our first video conferencing, we have them show us, not just tell us, but actually show us, hold up each medication that they're on. We validate that, yes, that medication has been prescribed. We go over the medication, make sure that they understand what they're taking. You know, oftentimes patients will go home from the hospital with new medications, but then they reach for that straw basket that's full of other medications that they were taking before, and they resume those automatically. We find some of our patients are taking more medication to be taking. So we validate those medications, and then, as I say, if they don't have a follow-up appointment with their physician, we basically ride them until they do. We just continue to stay on them to get that appointment set. Could you advance the next slide, please? So our goals and objectives really were to reduce the readmission rate for our patients with congestive heart failure and COPD. This is a multidisciplinary approach in that it includes the observation of their biometrics, asking them health questions. Patient teaching is a vital piece of this. During the course of 30 days, find them various videos to watch related to their health diagnosis. This device has 17 pre-programmed videos, so we're able to select particular videos that they should watch, and that's part of their daily health session. These videos are no more than 3 to 4 minutes in length. I think I've already mentioned the others, so if we could advance the slide, please. This is what the device looks like. As Dr. Snell mentioned, my team assisted in doing the technology evaluation and select device that we wanted, and the fact that video conferencing was important to us was a key player in that. If you look at this picture, you can actually see at the very top of the monitor there's a little hole. That's where the camera is, and that there's a slider so that patients actually can slide that over if they feel a little more secure, and they don't want to make sure that we can see them. We can't, but we have had some patients afraid that on them. So we've told them about that little closed camera window, and they have used it from time to time. And remember, we've got patients that are 89, 91. This was a very easy device for them to use. It's all touch screen, and it also speaks to them as well as they're able to read questions. And all the responses are just multiple choice so that they're able to manually touch the screen without having to type on a keyboard. The next screen, please. Again, this is just another view of the monitor. As you can see, the patient can go in and then select what they want to do. They can go in on the left-hand side of the screen. In the middle, there's one labeled Health History. Go in there and look at all of their biometrics. For example, I'm a doctor and I want to track all my blood pressures that I've taken in the last 5 days and take those into my physician. They're able to look at that, those numbers, write them down, and then actually take those into their physician. If you look on the right-hand side of the monitor screen in the picture, in the middle it says manual entry. Some of our patients have diabetes, and while we do not have a device that for their glucose readings, they're able to go in and enter and track those glucose readings just like they are the other numbers, so that they can take those into their physicians. In their contact area, they're able to write down key phone numbers that are easy to access, their physicians, their rehab clinic, family members, etc. And so there's a lot of different opportunities for the patients to go in and interact with the information available to them. Next slide, please. These are all the different participating hospitals. And I won't spend a lot of time on this, but I did want to show you that there's a very diverse group of hospitals that are involved in different sizes and locations. As Dr. Snell showed, with the state of Indiana, we are hitting about half of those. And so we've been very fortunate that we're working off of a cellular connection, and this minimizes a lot of the connectivity problems that we have experienced in the past using different types of connections. Not everybody has internet. The cell has worked very well in all parts of the state. We have had to use one particular, like Verizon has the most coverage in Indiana, so that was predominantly the card that we use. However, there are some pockets within the state that we use the AT&T cell coverage. So I think I had 1 or 2 instances out of monitors so far that weren't able to get any type of connection. Next slide, please. Values Relationship Incorporated, I already mentioned to you, so I won't spend a lot of time on this. But this particular device does require a third-party installer to go into the home and set the patient up. They also will go into the home and retrieve the equipment. They will physically clean it as well as decommission it, get all the patient information off of it, and they inventory our devices for us. So this isn't something that we handle. This third party takes care of all that type of operations processes for us. Next slide. A visual picture, as you can see, the blood pressure cuff, the patient slides it onto their arm. It provides instructions every time. So if a patient forgets, you know, where am I supposed to place the device, etc., it will walk them through each time if they want to, and can re-listen to the instructions so that they are taking their readings as accurately as possible. Next slide. This shows you the preliminary results right now of our patient activation measurement. As you can see, the control group, the responses are less confident of how to care for themselves, versus the right side of the column where it's the intervention. You'll notice also that so far we've been able to follow up with 52 of our intervention patients versus 42 of our control group. What we have found is that we don't always have accurate information for patients, or they've moved, their phone's been disconnected, etc. So we're able to capture less of the data with the control group. However, with the Indiana Health Information Exchange, we have put in a request to try to identify all the patients that have participated on the control side. So if we weren't able to reach them by phone, that we'll be able to find out if they had any readmissions and be able to include that in our final analysis. Next slide, please. Again, the entire survey is only 13 questions long, and it's all about their lifestyle changes and if they understand how to prevent their own problems and identify when they are starting to decline. Next slide. The preliminary findings so far, the intervention group, we've had 50 patients completed, and we currently have 4 active ones, and we've had 15 drops. On the control group, we've had 63 complete the program. Currently, we have 6 active, and we've had 2 people drop. So for right now, we're pretty even, 71 on both sides. The readmissions have been reduced significantly. We've shown an overall, based on our preliminary information, an 80% reduction in readmissions. And this is with a p-value of 0.04, which is significant. So the national average, is around 20–21%. So we're thrilled that we've been able to reduce our readmissions significantly. Next slide, please. As we are doing the readmission study, we've had surplus in devices as well as nurse labor. So we went back to Indiana Health Information and said, hey, would you mind if we did a parallel study, if you will, and included more patients? We'll keep the study clean, and we won't alter that at all. In addition, we want to also just expand this to other entities, hospitals. We want to expand the length of time, the types of diagnosis, etc. And so that's what we've been doing. And we've now got, as you can see, 6 different home health agencies that we're working with and monitoring their patients. We have a variety of different hospitals, as well as our care management organizations. Some of our physician groups have identified some very complex chronic patients that they have had difficulty keeping out of the hospital and stabilizing them. So we've had a lot of success. A little bit later, I believe there's a case study we're going to show with you of an individual we've been able to significantly reduce her readmissions. Next slide, please. Yes, this is the case study I was referring to. This particular individual has 9 chronic conditions. She had been admitted 13 times in the course of a year, and home health had actually enrolled her on 4 separate occasions and would not be enrolling her any longer. So her physician contacted Dr. Snell and said, I don't know what else to do. Can we put her on this and see if there's any way that we can act? And we really have. We have now kept her out of the hospital going on 7 months. Compared to the amount that we spent on this particular individual, we have saved $156,000 so far. This particular individual is a dependent of one of our associates, and that's how we were able to identify exactly what was spent in her care last year. So a lot of success, and I really attribute this to the relationship she was able to build with our nurse, and the communication that went back and forth on a daily basis in the beginning. She needed a lot of, and we've been able to build her confidence in providing her own care. We've worked closely with her primary care physician group and made sure that we were emphasizing the same points that they were trying to emphasize with her. and it's really been just a great success story. Next slide, please. So the lessons learned so far to date is we do believe that the video conferencing makes a significant impact on compliance of the patient through the relationship building. It provides engagement with that patient, and we feel like it is imperative the physicians are also engaged. I think this is probably the biggest reason that patients did not want to participate when approached in the study is because their physicians weren't engaged. So provider engagement is essential. The nursing interaction and socialization is extremely important, and responsiveness of the vendor. So whatever technology you might use, you need to be able to have a vendor that's very responsive to your needs, will make adjustments as you provide feedback to them on improvements, etc. And as far as technology, things that we have learned is the independent setup is essential for us going forward. To hire a third-party installer to actually have to go into the home and set it up in the patient's home and retrieve it is very costly. And there's now technology available on the market where that's not necessary. You need to have a flexibility of different devices. While the tethered device, and what I mean it's anchored into the wall, runs off of electricity that we're using now, and it stays at a particular site in the patient's home for the 30 days. Patients need to have a device that they can be mobile with. Particularly, you've got working individuals that need to be able to carry something in their purse, case that needs to be a small size device. There's a lot of pads available now, the iPad type technology. So the devices need to be flexible and pertinent to the patient that's using the device. Efficiency of clinical protocols. In order to make this type of program successful and financially self-sustained, you not only need to select the patient population that you're going to have the biggest impact on their readmission reductions and their admissions and necessary ED visits, but you also need to be able to scale up to a large number of patients that you're simultaneously monitor. And so therefore the care management suite of the technology needs to be fast and efficient, and you need to be able to switch just screens quickly and not take several seconds. Ease of protocol development. As we've expanded beyond just CHF and COPD, we've developed other protocols to be able to address the multiple diagnoses that we're now looking at. And you need to be able to adjust and change protocols easily in the back end. And again, the responsiveness of the technology vendor is very important. Next slide, please. The platform that we are looking at going forward, again, we want to stay with the cellular connectivity. Most of Indiana now has 4G, but it's not compatible with 3G. It really impacts the speed and the connectivity of the video conferencing. It needs to be secure and be HIPAA regulated, of course. And it needs to be simple and intuitive for patients to be able to use the device easily. This screen is no smaller for our elderly patients. This is a tablet, which is just sitting on a stand that the patient can take with them. But it also can be stationary if it's easier for an older patient to use. And I believe there's two parts to this slide. Could you advance it one more time? There we go. On the caregiver side, this is equally as important when you're looking at technology. You want to be able to have the real-time alerts. You want to be able to see the details of the patient monitoring, respond when necessary. You want to be able to create reports to be able to provide with the primary care physician. And it's nice that there is a portal so that not only the patients and their families can log on and see this information and print information, but also for the physicians as well. And the integration into the EMRs is another high priority for us. We want this information, whether them remotely or they're in the hospital, we want all that information to be going into their EMR so that their providers can see the entire picture of that patient. Dr. Snell, I'm going to turn it over to you for the slide.
Okay, thank you. Matt, if you'll advance to slide 26, I believe it is. There we go. So we'll wrap up here in the next few minutes because we want to make sure that we allow plenty of time for your questions. And this is now kind of our new vision. So as you can see from the previous slide that Julia showed, the nurse monitoring center, or what we're calling impact care center, and that's the call center with nurses and also non-clinical people or staffing. And we think we can scale up to where a nurse can be monitoring easily between 70 and 100 patients with some of that additional help. And so what we're in the process now doing at St. Vincent and with Ascension's help, and I think we're leading the way for Ascension here, is to connect with those patients longer than 30 days, because we know that was arbitrary as part of the study, but we want to figure out the criteria and stratification for patients with higher levels of acuity and monitor them longer if necessary, say between 2 and 4 months. We want to have also now patient education materials and engagement activities that we can deliver to them, because there'll be a mobile device, either theirs or ours, in their home. We want to now gather all of this data that's coming from these from this activity. In fact, we think over time that the amount of data here generated will probably be more than what you see in an EMR, and that because that's more episodic in nature, whereas this is more continuous and longitudinal. And then you see on the right how we anticipate that we'll have two-way communication with our EMRs, HR's system, and with the Indiana Health Information Exchange down in the lower right. So this is kind of our roadmap and what we want to do moving forward based on the results, based on the cost avoidance that we've seen in our study. And then we'll also be looking at ways that we can create a customized care plan or care path for every individual patient that's been identified for the program. If you go to the next slide then, Matt. So again, this is, and we'll finish up here, this is the care model based on that relationship that Julia cited, and we think that that's a very key component of this. It's not always about the technology, but the technology on the slide, as you can see, also provides a foundation for us to be able to connect with that patient in their home, and not just the patient, but on the previous slide you may have noticed it was also family members and caregivers. These care plans we want to put in the hands of everyone who touches the patient, and it would be a single platform, a single method that, and there would be questions there for the provider, for the other caregivers, and then likewise the interaction and their responses to their care plan, and are they meeting their goals. And we think that this is the way of the future because of what the accountable care model and patient-centered medical home model is going to provide for us in terms of changes in reimbursement and healthcare reform. So we really want to target these high-cost, high-risk patients first, and we'll be doing that within certain populations within St. Vincent and then Ascension, and even including our own employees and their dependents, we think is a good way to get started with that. So if I'd like to open it up now for Matt to take and we'll go ahead and answer some of those.
Sounds good.
Excellent, thank you. And once again, I would like to remind everyone that today's webinar recording and the PowerPoint presentation will be available on the Institute for Health Technology Transformation's website. Once again, that address is www.ihealthtran.com. We would now like to open up the presentation to answering your questions. As a reminder, to submit a question, please click on the Questions tab on your GoToWebinar toolbar. Simply type in your question in the provided chat box. Our first question from our audience is, how important will remote patient management be in the new ACO model?
Well, this is Dr. Snell. I just mentioned that, and I think it is very important. So as we're designing our model with our partner organizations, and there'll be other healthcare systems that will be partnering with us, a lot of attention is being focused on these transitions in care, how to reduce admissions, readmissions, inappropriate ER visits. We're even talking about how to reduce the premature infants using this same approach in high-risk maternity cases. And it's really, the focus now is primarily being shifted toward cost avoidance, whereas a lot of times when you put these programs together, you're trying to figure out what's the break-even point from a reimbursement standpoint, but I think in the accountable care model it really needs to shift toward cost avoidance. Julie, what else do you have on that question?
No, I don't think there's a whole lot to add other than it is an essential piece of the accountable care organization. I mean, it not only will impact your readmissions, which we're all going to experience soon, but it also allows those complex chronic patients to have better care and in their home. As we go forward to a different payment structure, it's going to make a huge financial difference for patients as well as providers.
Excellent, thank you. Our next question, what value does video conferencing add?
Again, I would say that video conferencing is extremely important. As it depends on the patient population that you are identifying, what level of care and interaction you need with those patients, but particularly patients with chronic diseases, they struggle a lot with a variety of needs, not just all physical, and being able to develop a relationship and let them know that there's someone there that is watching you on a regular basis and cares what happens to you, and just asks us all kinds of questions that they don't normally think to ask when they're in the physician's office. So again, I just think the relationship makes a huge difference.
Excellent. Our next question, besides collecting daily vitals, what else can providers accomplish by connecting to patients with mobile technology?
Well, and again, I think this is wide open now for us, and this is the area that we're really beginning to explore, because a lot of the home monitoring studies, and there are mixed results in the literature when you read it, depending on the technology, depending on how the study was designed, et cetera. But I think what we have learned from our study is once you have a mobile device that's easy to use and you don't have all the technical difficulties that you have with PCs or Macs, et cetera, if you have something easy to connect with the patient, then there's a lot more than you can do than just collecting vital signs. So now you have a portal by which you can help educate the patient, you can interact with the patient, you can involve the family members, the caregivers. You can do these customized care plans, which I discussed previously. So there's just a lot of opportunity there. And then in addition to just the biometric data that we're collecting, there are other types of data that you can collect on a patient in terms of activity levels. And where are they in their safety, in their home, particularly for patients with dementia or cognitive difficulties. So it really opens up a wide array of methods that you can connect with the patient and interact with them.
Excellent, thank you. Our next question from our audience, do you envision the patients bringing their own devices, and if so, how will you manage them?
Yes, I think going forward that will definitely be an option, and one that I hope comes sooner than later because of the cost factor. So as different vendors, I mean, there's two pieces to what they bring to the table. There's the software piece, which is all about managing the patient and their care, and then there's the device. And we specifically are searching out a vendor that is device agnostic. So it doesn't really matter what device we would use at the end of the day, that they could connect their software solution to that device, and we could. So I definitely see that in the future, and I know there's already conversations going on in the industry around that.
The other thing too, Matt, is we are exploring very exciting technology now that really, for a very minimum amount, like $50 or so, you can connect your television set and make it your home health station. And you can provide not only that educational piece where you're pushing content and information to them, but you're also collecting some of this information that we've been discussing, biometric and other information too. And that's really down at a disposable level, almost, where almost any patient could add if they certainly qualify. And then the ease of use, then use your remote control. So there are a lot of interesting applications that are being developed. There are a lot of interesting integration devices that are being developed, and the cost of all this is plummeting, absolutely plummeting. What we could buy the same device with more functionality now for about a fourth of the cost of what we spent originally in 2010 when we launched.
And are you using an electronic tool for the patient care plans?
Yes, and I'm glad this question was asked because I failed to bring it up. But moving forward, the customized care plan is extremely important because with the complex chronic patients, you've got multiple providers, and oftentimes one doesn't know what the other is prescribing or suggesting to the patient. So as part of embedded in the software that we're looking at with our next vendor, we're creating that care plan. And it will address not only specific tactics for their physical and physiological improvement, but it will also address their perceived barriers to providing their own care. Many chronic patients suffer with depression, so it will address some of those behavioral issues and help them. So we're really looking to use a customized care plan that would integrate all points of contact of care to that patient and share that with all providers.
How large of a patient population can a single impact center nurse safely monitor?
Well, we are actually, Julie and I and a few others have worked on a business case which we are presenting internally now for St. Vincent and Ascension. And we're looking at getting started here soon and scaling up to 400 patients fairly quickly. And then we may actually go beyond that depending on those results. But we feel that we could probably monitor and interact with several thousand patients if warranted across multiple populations, obviously. And not just here in Indianapolis or Indiana, but across Ascension Health. So we anticipate this scaling up rapidly over the next few years.
And it depends on how you structure your care internally, because if you're talking how many patients can one nurse monitor, we're looking at moving forward with utilizing LPNs, since many of them have been phased out of the inpatient setting. This is a great resource that can watch patients on a regular basis, and you've got the RN care. So the RN's there to, as needed, but then the RN is going to be responsible for creating that customized care plan. So it depends on how you build the structure of your team. Right now we're looking at one LPN will be able to monitor 75 patients, and you'll have one RN that will oversee 125 patients. Remembering the RN will not be looking at all those vitals and question responses coming in. That will be the LPN. So it depends on how you structure it and how critical the patient population is that you are monitoring.
Excellent, thank you. And unfortunately, that is all of the time we have for today's presentation. And once again to our presenters for today's fantastic webinar. Once again, for those interested, please visit www.ihealthtran.com to download today's recorded webinar and PowerPoint slides. With that said, we wish everyone a fantastic day, and we look forward to connecting again in the future. Thank you.